Okay, we're going to talk about Chapter 41. This is Part 1. We're going to discuss gastrointestinal issues in pediatric patients. First, let's talk about the A&P review. Like everything in babies, the GI system is also immature. Babies have a smaller stomach, plus the increased motility, which will equal more frequent feedings. Digestion occurs in the duodenum as opposed to the small intestine. Babies have deficiencies in digestive enzymes, amylase, lipase, trypsin, until they're about 4 to 6 months of age, which is why solids are delayed until then. That's also why babies are so gassy. So if they're having difficulty, some common signs and symptoms would be growth failure. This is defined as weight below the 3rd percentile, BMI is less than the 5th percentile, or decrease in established growth pattern. They may have spitting up, regurgitation. They could have nausea, vomiting, diarrhea, constipation. Constipation is defined as a difficulty with passage of stool for 2 weeks or longer. They can have encopresis, is the stool that stains in the underwear of kids, and it's a sign of constipation. You can have abdominal pain, distension, gastrointestinal bleeding. GI bleeding can be upper or lower and can be acute or chronic. They may have jaundice, which is associated with liver dysfunction. They could have dysphagia or dysfunctional swallowing, or they could even have fever. Nutritionally, your text goes into a lot about vitamin, protein, mineral deficiencies. Everyone has had a nutrition course, so if you need to brush up on this, please use your text. Look at box 41-3, pages 1255 of your textbook for complete descriptions of GI dysfunction and clinical manifestations. Food allergies are also an issue in the pediatric realm. You have gone over anaphylaxis already, so this should just be a brief review for you. A food allergy is defined as an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. Intolerance means that there is a reproducible effect, but not likely from an immunological mechanism. Recommendations include to breastfeed infants exclusively, remember from 4 to 6 months like we discussed earlier. Soy formula is not recommended to prevent development of food allergies. Do not wait beyond 6 months to start solids. Hydrolyzed formula may be used for at-risk infants to prevent a modified food allergy. Do not make maternal restrictions during pregnancy to try to prevent food allergies. You want to continue with vaccines even with egg allergy unless a severe reaction occurs. And for severe egg allergy, make sure they don't get an influenza vaccine without considering the risk versus the benefits. Some manifestations of food allergies include systemic, which would be anaphylaxis or growth failure. For GI, would be abdominal pain, vomiting, cramping, diarrhea. For respiratory, they could have cough, wheezing, rhinitis, or infiltrates. And then cutaneously, they could get the urticarial, a rash, or atopic dermatitis. For oral allergy, common triggers, I want you to look at box 41-1 at page 1251 of your textbook. It can occur from IgE mediated or IgE non-mediated immune responses. The body is exposed to allergens that can make the IgE antibodies when ingested. Usually, there are no fruits or vegetables. When eaten, they can cause edema, itching from lips, tongue, palate, and throat. Recovery is usually rapid. If a child has a parent with a food allergy, they have a 50% greater risk of developing a food allergy too. Common triggers can be nuts, eggs, wheat, legumes, fish, shellfish, soy, chocolate, milk, buckwheat, pork, chicken, strawberries, melon, pineapple, corn, citrus fruits, tomatoes, spices, and for reasons unknown. Most children allergic to eggs and milk outgrow the allergy by 3 to 5 years of age. So let's talk a little bit about the pediatric epidose. Epinephrine is 0.001 milligrams per kilogram up to maximum dose of 0.3 milligrams. EpiPen Jr., that's a 0.15 milligram, is usually for 17.5 to 55 pounds. Then the EpiPen, which is 0.3 milligrams, is usually for 55 pounds and up. Okay, let's talk about lactose intolerance. This is going to be a brief review since we discussed it previously in another course. It's the inability to digest lactose, such as disaccharide found in milk or dairy products. It can be congenital or acquired lactase deficiency, results in diarrhea, gas, pain. It's diagnosed by hydrogen breath test or symptoms. Treatment is lactose-free diet and lactase enzymes. Look at box 41-2 on page 1253 of your textbook. Dehydration is a topic that is covered in depth in the medical surgical section, particularly in the fluids and electrolytes. So again, this should just be a brief review. It occurs whenever total output of fluid exceeds the intake. This is very common in children. Causes could be insensible fluid loss, increased renal excretion, GI tract dysfunction, vomiting, diarrhea, ketoacidosis, or even burns. So types of dehydration, you want to be sure to review the types of dehydration listed on pages 1255 to 1256. Signs and symptoms are in table 41-2 on page 1257. Compensation mechanisms are on pages 1256 and 1257. Diagnosis is in table 41-1 on page 1256 for evaluation of the extent of dehydration, and then look at table 41-2 on page 1257 for clinical manifestations of dehydration, and note the differences based on the type of dehydration. For management, we have oral rehydration for the alert and oriented kids. We have IV rehydration. It's usually 0.9% sodium chloride or lactated ringers. Symptoms include tachycardia, dry skin, dry mucous membranes, sunken fontanelles, coolness, mottling of skin, loss of skin elasticity, and prolonged capillary refill time. Look at page 1257 and the table 41-2. Compensation. Interstitial fluid moves into the vascular compartment to maintain blood volume in response to hemoconcentration and hypovolemia, and vasoconstriction of the peripheral arterioles help maintain central circulation. When fluid volume is so great that it cannot be compensated, then the blood pressure falls and tissue perfusion is compromised. This leads to hypoxia, accumulation of lactic acid from anaerobic metabolism, pyruvic acid, which will lead to metabolic acidosis, ultimately that leads to shock. The kidneys also do their part to compensate. They concentrate the urine down to conserve water. So how many of you have tasted Pedialyte, especially in the unflavored version? It's gross. Sweeten it with Kool-Aid. It can also be used as popsicles. Try rehydration with 2 to 5 mLs every 2 to 3 minutes. IV rehydration usually involves an isotonic solution like 0.9% sodium chloride or lactated ringers. The goal of phase 1 of IV rehydration is to expand volume quickly and improve circulatory and renal function. So a bolus of 20 ml per kilogram is given and may be repeated. Then phase 2 begins, which is to replace the deficits and meet maintenance water and electrolyte requirements. Phase 3 is to wean off the IV fluid and begin the PO intake again. Look at table 41-3, box 41-4, and table 41-1 on page 1258 of your textbook for rehydration. Let's discuss diarrhea. Acute diarrhea is the leading cause of illness in children less than 5 years of age. Of all deaths in developing countries, 24% are related to diarrhea and dehydration. Diarrheal disturbances have several forms: gastroenteritis, enteritis, colitis, and enterocolitis. So let's talk about the types of diarrhea. First, we have the acute diarrhea. It is less than 14 days and associated with the upper respiratory infection or a UTI and antibiotic use or laxative use. Then we have the acute infectious, which is caused by a variety of pathogens, which we'll discuss on the next slide. We have chronic. This is caused from malabsorption disease, inflammatory bowel disorders, food allergy, food intolerance, and etc. It's diarrhea that lasts more than 14 days. Then we have chronic nonspecific. This is called a toddler's diarrhea. Common from ages 6 months to 54 months. You can't find a cause for it. The children continue to grow. They don't show signs of malnutrition. They have loose stools with undigested food, and it may be linked to food sensitivities or artificial sweeteners. Okay, common causes of diarrhea in children include rotavirus, salmonella, shigella, campylobacter organisms, Giardia organisms, Cryptosporidium organisms, C. diff, Plasmonas, Yersinia organisms, or antibiotic effects. Look at Table 41-5 on pages 1260 and through 1262 for the complete descriptions of each. Okay, we're going to talk about diarrhea management. There's an assessment of fluid and electrolyte imbalance. We provide rehydration such as oral rehydration therapy, also known as ORT, intravenous rehydration, maintenance of fluid therapy. Look at Table 41-6 on page 1264 for treatment of acute diarrhea. We have reintroduction of an adequate diet, and you want to teach parents about diarrhea prevention. 2 rotavirus vaccines are available. Teach personal hygiene, clean water supply, protect from contamination, teach careful food preparation, and encourage hand washing. We're going to talk about Sprung Disease. It's a congenital ganglionic megacolon. More common in males than females. It can occur by itself or with heart defects or chromosomal anomalies. It results in inadequate motility, obstruction of the intestine. So basically, the absence of autonomic parasympathetic nerve ganglion cells in the rectum or colon prevents peristalsis at the point where the ganglion are absent, and thus kids can't poop, and they end up with an intestinal obstruction of poop, usually limited to the rectosigmoid colon. Symptoms will depend on when it's diagnosed. In newborn, failure to pass meconium within 48 hours, abdominal distension, inflammation in the intestines, and bloody diarrhea. Older infants, they will have a failure to gain weight, malnutrition, chronic constipation, fecal impaction, and may have a history of pencil-thin stools. Look at box 41-5 on page 1268 of your textbook. Diagnosis is made by an X-ray, a barium enema test, and finally a rectal biopsy looking for those nerve endings. If they don't find them, then they keep going up the rectum until they do. Then if they can, they take out of the part that's missing the nerve endings and pull the good part down to the anal sphincter. If too much of the colon is not innervated, then a colostomy is always an option. Nursing care. You're going to place an NG tube. You're going to provide IV fluids. You're going to make them NPO status, and we're going to give antibiotics. So why do we want to give antibiotics? Well, this is to prevent enterocolitis, a serious complication that can occur before or after the surgery. You may have possible saline enemas pre-op. Then you will probably provide pain meds, take vital signs, accurate intake and output, and wait for bowel sounds to recur. Okay, we're going to talk about gastroesophageal reflux versus gastroesophageal reflux disease. First of all, there is a difference in plain old gastroesophageal reflux and GERD. Plain old gastrointestinal reflux affects about 50% of infants 0 to 3 months. There is a higher incidence in preemies, and males are affected 3 times more than females. With just plain reflux, babies still gain weight and they don't have excessive crying. They don't develop esophagitis. Yes, they spit up, but still overall they gain weight. In GER, the lower esophageal sphincter relaxes, which allows passive regurgitation of stomach contents into the esophagus. A potential risk of aspiration exists. However, GER is not as serious as GERD, also known as GERD. Look at box 41-6 on page 1270. GERD is much more serious. You could tell because the name disease is present. It's characterized by poor weight gain, failure to thrive, a lot of crying, arching of the neck, very irritable. They have persistent respiratory symptoms such as apnea, cyanosis, wheezing, cough, and pneumonia. It is associated with neurologic disorders, syndromes, chromosomal anomalies, and other disorders. It requires treatments such as PPIs, like Prilosec Prevacid, or H2 blockers such as Zantac or Pepcid, or surgery, which is a Nissen fundoplication. That's where they wrap the fundus of the stomach around the esophagus. G-tubes are usually inserted at this time to vent the stomach and for feeding if needed. Then we have the potential for intestinal parasites. In humans, it's caused by a variety of organisms. Two most common in the United States are the Giardiasis. Look at box 41-7, and then of course pinworms. Look at box 41-8. Be sure to review nursing care for intestinal parasites on page 1272 to 1274, and then table 41-8 for the most common intestinal parasites. This concludes Chapter 41, Part 1.